So we're here to take a look at a concept that we've dealt with before, which is treating the facial structure and the TMJ. We're going to look at it in what I would call a very odd clinical circumstance. So the idea that you would be working on a patient's facial structure or jaw when they were in a seated position is not something that you would commonly find, something that you would commonly choose to do. But what this does is it allows us to take the concepts that we've shown before and highlight them and how you would alter them and how they would be the same, right? So relational motion still counts, contact as control still counts, patient positioning in the situation where less stable means I need to make the patient more stable, so the patient's seated on a stool in this situation. These are all things that are going to count, they're all going to matter, but we're going to display how that creates a change and how we need to adapt to that. So the first thing that I'll do is I'll just look at the facial structure. So in a previous video that I've done on working on the facial structure, I've suggested that the mandible and, the maxilla and the nose itself are good handles to work on the facial structure and that you will get some glide. Right, so the patient would have been laying on their back and I would have come to the side and I essentially would have put like a hook, kind of a hook grip around the maxilla and created some form of glide while stabilizing the head. Now because the head's not on a table, I need to be more careful, right? So I'll show you what it looks like, right? Now if I'm out here, right, and I come in, first the patient has to know, so you let them know what you're going to do, right? I come in here and I start to do this, I have very little control, right? Like the patient's head, I'll move the patient's head. My hand up here, if I'm not paying attention, can just wiggle the patient's head. So I'm going to come in and essentially come very tight. My abdomen's on the patient's body, and you can see the second I do that, I wiggle them. Right? So I have to know that that's going to happen. The other thing that I'm going to do is I'm basically going to have my forearm on as much of the patient's head as I possibly can. Now I'm also in a position where I can't see, so the idea of patient positioning where we want the anatomy exposed, free to move in the plane or planes required, and preferably visible. I can't really see this appropriately, but I can get some idea off of kind of peripheral vision. Now what I can do is I can create my glide, so I can pull towards me and away from me. And I can use my vision to the best of my capacity to see what's going to, or where some motion asymmetry is, keeping in mind that I do not have a good view of it. Right? I can hold for essentially MFR, right? So this is all patient passive. What I can do is I can pull towards me and I can say, just very, very gently turn your head to the left, very gently, perfect, and then relax. Very gently turn your head to the right, and relax, right? So we can have our patient active there. Now the exact same thing applies if I go into the nasal structure, right, or into the nose. Now in this situation, I have my good contact with my forearm, broad contact for multi-point discrimination, also contact as control, and I'm going to be nice and tight to the patient. And because I'm coming into the nasal structure, I may be able to kind of tweak around, get a little bit better vision here, but same deal. Right? Push and pull, so that's passive, and then if I want to go active, I can have him turn his head left and right. Now, with respect to something that Dr. Still had talked about, using the thumbs to essentially draw the nasal bones down, because I'm going to do, usually you would do this if the patient was laying on their back, they were in supine, so you'd be able to see everything. Now my problem here is, if I want to do this in the way that Dr. Still talked about it, in supine, I can't see his eyes, so I need to come around, make sure that I'm not going to poke him directly in the eyes. Now I can come here, I can basically bring him back into me, right? So you'll see I use my forearms to control. So now I have good control because I basically put his thorax onto my abdomen. I'm leaned over a little bit. I've got my thumbs on those nasal bones. I can do a draw down. Now the problem here is I can't do this passively because I'm just going to basically pull his head down or move his skin. So if I hold on to his nasal bones, and what I have him do is, I just want you to look up to the ceiling, so just try to tip your head up to the ceiling, just nice and easy, and let go. Good. Tip your head down, right, so that just takes it down. That doesn't really do much, right, so essentially you're seeing an experimentation process here as well. So just look up to the ceiling, just nice and gentle, just real gentle, and then let go, right, so you still have contact, right, lots of contact in that situation, so you can adapt the nasal treatment that Dr. Still talked about to a seated position. It is not ideal. I can't see what I'm doing. I can very easily poke my patient in the eyes. I don't have good leverage. This is a problem. I can do it, but it's a problem. Now the next thing we want to take a look at, we're just going to turn and face this way. So just shimmy over. Essentially, we take a look at the the TMJ. Now, because I would work on the side that I'm on. However, just to show you about the muscles of mastication here, right? We talked about the muscles of mastication kind of coming from the ear tab, and then or coming backwards, right? So you essentially go into the region of the maxilla, you go backwards. It's like somebody's trying to pinch your cheek. So here you can see I can kind of create a pinch, right? So I got a bar, and then I can push and pull perpendicular to fiber direction on the general region where the majority of the muscles of mastication are going to be attaching into the mandible, right? So I've got that, right? My perpendicular to fiber direction, relatively still head, I move the muscles, relatively still muscles, I move the head, so that's all patient passive. So we'll just turn to your left, head to the left, head to the right, right? So there's my patient active, just head to the left, head to the right. I still need to keep my patient in some control, right? So now that's where you see my ability to work on that soft tissue. You may see me, if I want it to work bilaterally, I may come in here, right? And again, I can't see, so I want to make sure that I peek around and I can see, so I don't poke them in the nose, I don't poke them in the eyes, and then I can just do my drawback as if I did it in supine, just coming from the anterior border and working backwards. So my passive is just this. I can turn his head a little bit with my thumbs, or I can have him turn his head, which I don't need to do. Now the jaw itself, right, so the TMJ, so I come in front of the ear tab, open your jaw all the way, good, let it close, right, open it all the way, good, and let it close just gentle, don't go all the way, so open it all the way, close just a bit, and open all the way, right, and then let it go. So that's essentially wedging in behind the actual superior portion of the mandible where it attaches into the temporal bone. So you're kind of right posterior to the joint and you can wedge in there. Now, another thing that you can do is generate a lot of leverage. I wouldn't suggest this in many situations, but you can generate a lot of leverage here. So just have you put your hands over there. All right, so now, as long as somebody's comfortable with their face on your midline, you just bring them forwards, right? And you can come in behind now, right? So this generates a lot more leverage. So open your jaw, good. Now you can slide right in back behind the mandible itself, a little lower, and then just close it just a bit, right? And then let it go. So that's kind of patient active. What I can also do, open your jaw all the way, good. I can draw it forwards. Now look up to the ceiling. Keep the mouth open, drop the head down, just down to the floor. As he drops it down to the floor, I get a bit more of a pull on that. So he's got his jaw open and let it relax. And I can get that so I can start to mix my patient active and my patient passive in that situation. Another thing that I can do is just turn your head this way, right? I can come in behind, so his head's stabilized on me, so this is contact as control. And come in behind the mandible here, good contact, right? So I kind of wrap around. I can draw this way, I can draw the mandible this way, and turn the head the other way. All right, so this ends up looking much more like a grappling match, but one of the reasons that we're able to use this is because we've got so much contact and so much control. So if you really need to pull on a jaw very firmly, which is unlikely, you may want to do it in a seated position where you can get a good draw here, right? So you can, when I say draw, I mean drawing of the mandible forward away from the temporal articulation. Right, so that this is passive where I turn and pull. What I can do is have him turn his head to the left. You won't see much here, and then relax. You won't see much, but as long as it's a small turn, then I can have good control and I can really hook onto the bone and have him move. So the big deal here is that you're seeing me alter things that I've already shown into a seated position, where we want to really be sure that because we won't be able to see everything that we're doing, we check where we're going with our eyes before we put hands on. Otherwise, we're likely to poke our patient in the eyes with the nose, so we need to make sure that we're looking, and we need to make sure that we have good contact and good control, which we've already essentially shown. So keeping in mind that what I'm showing you is an alteration on stuff that I've already shown from a supine position to a seated position, this all can be done. And the reason I present a hierarchy of patient positions, as far as control is concerned, so the table makes stable, less table means I need to make the patient more stable, space between us is unstable, and then ideally I want to make my final choice as to where I put a patient by I'd like the anatomy exposed, free to move, and the planar plane is required, and preferably visible, is so that I don't run into the situation like this, where I may accidentally poke people in places that I shouldn't be touching them, or that are going to be very uncomfortable. So the reason I have all those hierarchies and I put them out is so I don't have to make all these adjustments. But if I do have to make the adjustments, I know how to, such as contact is control, control is safety, relational motion, working perpendicular to fiber direction. I've got all these things that set me up so that I can make the choices and make the adjustments without having to think too much. Now, early on when you get these concepts, you may not necessarily know how to wield them, which is why I show you as many different ways as I can so that you have some idea of how to wield them. You can go experiment, and as you experiment, you implicitly build your bank of understanding how to change these things. So always take these things, experiment with them, work with them, because at first they'll feel awkward to you. You may think that what I'm saying makes sense to you, or I may think what I'm saying makes sense to you, but you actually need to put it into your own hands and start to wield it a little bit.